Hi, everybody. I'm Francois Venter. I'm based in Johannesburg. I'm a clinician looking after people with HIV, and I'm more recently involved in COVID research. I'm here to talk about healthier living in HIV-positive people, and specifically look at the data. And I was hoping to make the presentation somewhat controversial, so I'll take you through a very rapid series of slides, a cook's tour, and then we'll pivot a little bit, and hopefully you'll have some fun. So these are my disclosures. I've also listed my BMI at the end there, which you'll see why they're so important. I think the first thing about HIV that has been unbelievable success is that we have made sex safe for both people without HIV. PEP and PrEP are very, very safe and provide almost total protection if people are adherent. And people on unsuccessful antiretroviral therapy have undetectable viral loads, do not transmit the virus. And PrEP has really been a game changer in the last while in terms of a sex worker program that I'm involved with in central Johannesburg. We haven't had a single documented transmission yet in a hyperprevalent area. And this fits with other very high risk groups that are mentioned here on the slide amongst gay men. So really, this has been an incredible success for the HIV world. We've also seen, thankfully, the end of the when to start debate that has occupied me and a whole range of my colleagues in this area, that as we got safe tenofovir and then steadily safer drugs, we've dropped the CD4 count thresholds and we try and treat people immediately, preferably on the same day that they're diagnosed. We've seen the benefits of this in terms of decreased transmission. I'm not sure everybody knows this, but a fairly dramatic reduction in new incident infections over the last few years, both in South Africa as well as in the region. But we've seen it in richer countries. Many of these decreases have been driven by PrEP. And I think many of us are very uncomfortable with the end of AIDS rhetoric, but certainly widespread provision of antiretroviral therapy for treatment and prevention has made an impact. And we've seen the impact on TB. We've seen, this is a very elegant little study showing that the more ARVs you initiate, the less TB there is in every single province in South Africa. There are problems, and this is, I'm hesitant to use the word stubborn, but this group of patients who just seem, it doesn't matter whether you live in London or Johannesburg or Delhi, there seems to be a proportion of patients who seem to be arriving late for therapy. In South Africa, we have very good data demonstrating that the percentage of people coming in with low CD4 counts hasn't actually budged much in the last 10 years. And we see this with the cryptococcal patients who, where the numbers where we've got a very good surveillance program, but the number of cryptococcal patients hasn't really changed. So the good news is that everyone's getting older on antiretrovirals. In fact, in some studies in Europe, in the UK, and even in DC, and even in places like Uganda, demonstrate a normal, even longer life expectancy than the general population. And particularly, and it's very important, this, if you diagnose people with good CD4 counts above 350, above 500, they're going to live forever. With it has come a whole lot of changes in antiretroviral regimens. The integrase inhibitors have made their way into first-line therapy, both in richer countries and now across Africa and Asia, and many other poorer countries. And it fits with just the evolving antiretroviral paradigm, where we had patients taking dozens of toxic tablets 15, 20 years ago. We now had a situation where we're looking at drugs, exciting drugs like islatravir, which might even be able to be administered as an injectable every few months or even as an implantable. So we really have moved the dial dramatically in terms of treatment. It's bizarre that weight gain is the major side effect of modern antiretroviral therapy. When I think of where all of us clinicians were involved 20 years ago, weight gain was not something we were really worried about. But it's not just weight gain. There's also the issue of neural tube defects, and the safety of these drugs needs to be looked at in different cohorts. But certainly, I'm going to be talking about weight and weight gain, and hence my comment about BMI early on in the lecture. But we can improve antiretroviral therapy. We can improve all sorts of things associated with HIV. And you can see here this Lancet paper, which is a little bit dated now, but said here, less toxic antiretroviral drugs, improved adherence, prophylactic measures, and management of comorbidity is really important. But I think it's really important for us to start asserting this. HIV is essentially a non-communicable disease. If you treat it, it becomes like diabetes and hypertension and everything else. So I could end the lecture here and say it's all very easy. We need to diagnose everyone, preferably in the day of them being infected, but ideally with a good CD4 count. We need to promote adherence to the medication, and we're doing that with these safer, more convenient drugs. But we also need to pay attention to the social context. I'm not going to talk about this because it's very different. You can't look in Johannesburg and then look in Russia and then look in Brazil as to what issues such as substance use and mental health issues, but these are generally under-addressed in terms of HIV care. As I mentioned earlier, we need safer generations of drugs. I haven't talked about this at all, but we certainly underutilize INH prophylaxis, which is very, very effective in stopping TB. But in high TB burden countries, we need this. And then we need to start thinking about the consequence of aging and HIV inflammation. And here's where I want to pivot a little bit. I want to change the subject, controversial, hopefully a bit more interesting. So this paper, which came out in 2013, which was written by the late Martin Fisher and Vanessa Cooper, started to question this idea that people who are HIV positive naturally age more aggressively. And it actually threw into, for me, certainly raised the issue of what exactly are we dealing with here when it comes to some of these non-communicable diseases that are associated with aging, everything from diabetes to hypertension, all the rest. And I think what I want to plea for from this lecture is that we need to start insisting on the levels of evidence that we had with HIV to the rest of medicine. So much of medicine just seems to be, just intuition and made up to my mind. And I'll start taking you through, and I'm going to use obesity because that, I think, for us in HIV is the major side effect of the antiretroviral therapies, or possibly not, and throws into relief a whole lot of questions that we need to be asking. So I love this graph because it shows essentially Immanuel Kant talked about the good life, and I suppose in health we want the perfect life. Is we want to be absolutely healthy, maybe take a few tablets every now and again, and then you want to drop dead, preferably of a massive ischemic stroke while playing golf at the age of 93. So that would be a perfect life. We have to die of something, but while we are alive, we want to be healthy and happy. And what we've done, not just this is with all diseases, is we've had a major impact on infectious diseases. Eradicate's a bit strong in terms of especially in the COVID-19 era. But even in places like Europe and America, rich places, infectious diseases extracted a terrible toll, TB, pneumococcus, even into the 40s and 50s. So fairly recently, but that has been taken care of with better living conditions. And now dealing with chronic diseases is what's happening so that you can get your golf course. Now, this looks to me like HIV. We have taken care of the viral load, and now we're dealing with the consequences of the chronic diseases. This philosophically, though, is important to remember, is though we might be giving people lots and lots of extra years, we need to be clear that actually some of those years are not very high quality. And certainly we don't help as the medical profession, especially when we insist on people attending clinics with long queues or to engage with dangerous and painful prevention processes. Barbara Ehrenreich wrote this really interesting and savage, she's a basic scientist, book about the wellness industry and about everything. She tore apart things like annual physical examinations and then everything else that is just, come into faddish things like meditation and all sorts of things which are promoted often by the medical industry as reasons to age healthily. And these books, these are not fad people. These are not nutty people. These are people from our industry, strong researchers who've started to write books questioning a whole range of medical intuition and data. And this quote from Bad Medicine lived with me is that until the 70s, homeopathy actually outperformed medicine, mainly because homeopathy didn't do any harm. It did nothing. But medicine did a great deal of harm. And I think, again, we need to be looking at things like obesity and asking some harsh questions about what the recommendations are that we're putting out there. And it's not just obesity. There's a whole range. I'm not going to take you through these. And I bet you there are a whole lot of people on watching this lecture are outraged and can point me to other papers. But these are all major papers from credible journals questioning a whole range of interventions that we've held up. I'm going to focus on obesity, but just to say that in medicine in general, a lot of what we've prevention is better than cure sounds good, but actually there's a great deal of harm and a large number of people who benefit and get rich from these interventions. And I love this quote from Professor Lucy Allais at my university, is that where health advice is not based on actual evidence, it is likely to give expression to individual and social intuitions. And these frequently seem to express Calvinistic, moralistic ideas of how it must be improved by self-denial and suffering. And that certainly has been my experience of medicine, is if it makes you feel good, it can't be good for you. And I love this meme on the right about how to live a long and healthy life. So let's talk about obesity. And that obviously, everybody knows obesity is bad for you. Your fat is bad. And this article in The Lancet, which I've been teaching off for the last few years, does seem to suggest that across every single continent, obesity is associated with, particularly BMIs of over 30 are associated with poor outcomes. But this study, which I put on a previous slide, actually did look at this. The DAD people are very cerebral, considered sober people, and they looked at BMI and actually demonstrated that it wasn't associated with worse outcomes in terms of cardiovascular disease, certainly not in the short term. There was increased diabetes, but not necessarily clinical outcomes. And I think I'm coming back to the obesity thing because lots of people like me now, I've got a new lease on life as a researcher looking at obesity. The pharmaceutical companies are obviously tussling as to which drugs, ARVs, cause less obesity. And large donors like PEPFAR and many governments have invested in dolutegravir. So if they are causing obesity, they stand to lose face and having to explain why they're giving this terrible side effect to people. What's interesting here is that I think we need to understand as a medical profession who we collude with. There are lots of people who really want to make you feel horrible about yourself and about your body, and it's implicated in all sorts of mental illness. And we made many people rich with again, all these associated industries without much evidence to suggest it. And I'll just take the diet industry, which is one of the worst ones as far as I'm concerned. But anybody knows, I think we all know that probably processed carbohydrates are not good for you. But beyond that, there's a lot of skepticism about what is actually a healthy diet. And these are just major papers I just took off from various diets that have been tried over the last while. But if any of you know what a healthy diet is, please email me urgently. Now, being obese, we all, as medical professions, know is associated with a whole lot of outcomes, many of which are not good for you. It's important to look at those first three and understand that those are actually asymptomatic markers of disease. They're not actual clinical outcomes. But there are all the others which are associated. And again, this Lancet paper, which looked at this, and I've just flagged, obesity as a major issue for COVID outcomes. But then what's really important, I love this Nature article that was published now quite a while ago, that said actually being skinny is really bad for you and is associated with other bad things like mortality, which is a fairly bad thing. And you can see here that as you get older, being skinny is actually a much worse outcome than being morbidly obese, having a BMI of over 40. So I think what we're saying here is that I used to joke about this and say if we were going to be evidence-based, we'd have McDonald's in the HIV clinics where everyone was skinny. That's no longer the case anymore, thanks to our new ARVs. But this is something that's important. And this study, which Mark Seidner's group did in rural KwaZulu-Natal, looked at it's hot off the press in obesity, demonstrated again, and this is on the back of multiple other studies, that our normal values, what we think is normal, what is associated with low mortality is actually skewed. And in fact, in this cohort, being obese was good for you. Now, Catherine Flagel is this amazing researcher in the US, has been saying this for years in multiple articles. And in this savage editorial criticizing the Lancet paper at the bottom on the left, with a whole range of very famous epidemiologists, has been taking apart this obesity paradox and saying it's not a paradox. There's tons of data out there that so-called obesity is actually does not have the consequences everyone's ascribing to it. And in fact, being skinny is actually a bad thing. And Kirsten Dunkel, who is an amazing researcher here in Cape Town, actually said, if we were given this, if we weren't told fat is bad for you, we would be supersizing everybody based on the data, this observational data that we have in front of us. We've used observational data to inform a whole of weight loss implication interventions, but not the other way around. So I'm ending my talk by saying, like, some of this is just needs some sensible people to be taking a step back and looking at this. I just took this slide off an aging lecture, which is about the general population, not for HIV, and all the usual stuff around blood pressure, glucose, lipids. We all know smoking is bad for you. We all know exercise is good for you. We know everybody should be screened, should get their pap smears and get the immunizations. But what's interesting to me is that the last one, there's an interesting paper in Science looking at social contact and isolation, saying it was the severe social isolation is the equivalent of smoking 20 a day. Now, we have 30 different blood pressure guidelines all over the world. We don't have a single WHO guideline on how to avoid social isolation. And I think, again, we need to start focusing on the things which are actually going to affect our patients' health. So maybe it's not that easy. Maybe all those things I mentioned earlier, as HIVologists, we can do that. But I really think we need to take our cynical, hardcore HIV demand for evidence culture that's built up, I think, in the HIV world and start demanding it of the rest of medicine. We cannot have these interventions being put on our patient population without decent data. We need RCTs, we need decent clinical trials, we need proper data that is not confounded and is not all full of moral intuition. And again, we need to have a lot of introspection and humility about those 4 score and 5. Make our patients happy and healthy, not necessarily unhappy and healthy. And preferably, obviously, not unhealthy and unhappy. And at the moment, I worry that much of what we're doing at the moment is making them unhappy and and potentially actually harming our patients. So again, let's demand the hardcore HIV evidence base of the rest of our colleagues in the rest of medicine. Thank you very much.